So, I suppose the next thing is really to explain what this is all about and justify ourselves in dragging you all here on such a beautiful day. So this is part of a cause health. Some music in the background. Cause health project. Now, Ronnie, you want to stand up? Ronnie Angem is the leader of this Cause Health project. Ron is based in Norway, in the Norwegian University of Life Sciences, just south of Oslo. And Stephen Mumford is also a leader in this project and the projects before that. So these two people are not physiotherapists, they're philosophers. And the idea of today is really to bring philosophy and physiotherapy together, because the Cause Health project is about that. It's about the Cause Health project is a philosophy project, looking at the philosophy of science and some of the deep fundamental questions of how science works and the nature of some of the principles underpinning science. The main principle being that this thing called causation. And it's just sort of emerged over time that physiotherapy as a discipline sort of lends itself as a sort of example to sort of test some of this work out. And I think one of the reasons for that is because physiotherapy is sort of more clearly complex and context sensitive and messy and not poorly defined, but less well defined than some other sort of healthcare disciplines or other scientific disciplines like physics or something like that. So it's a really nice environment to talk about some of these complex problems. And the core of today and the core of the project is this thing called causation. So what I'm going to try and do now is explain a bit about what that is and what that means, and why we think it's a problem, and why we think it's worth having a very generously funded 4-year project in philosophy to try and explore that. And we're still in the first year of the project. So this is the first year of a 4-year project. So leave now if you want, but there'll be no answers to anything today. We're not going to sort of reveal a secret thing that causes all your patients to get better tomorrow morning or something like that. So we'll leave with far more questions than we'll have answers, but hopefully those questions will be really important and meaningful, not just to the discipline of philosophy, but of course to understanding what we do. And Ewan Ellis put this up on Twitter not long ago, and I think I was trying for ages to try and find a way of explaining what today is all about, and then I saw this cartoon and really, this is it. It is about being pedantic and philosophical and asking questions like, when we say something like, does it work, what does that mean? I mean, what does mean? What does it mean? But more importantly today, we want to try and work out what this notion of work means, and we're taking work as a causal term. When we say something's clinically effective or not effective, or a treatment works, it's really what do we mean by that in a scientific context. So what is the problem with evidence-based physiotherapy? So obviously the evidence-based practice framework is again a suitable and relevant and the best framework to sort of play some of these problems out in. And so to problematise it, the first thing I really want to say is this doesn't mean we're being negative or we're sort of deconstructing things and saying, oh, this is rubbish and this doesn't work. It's sort of the opposite of that. Problematising something is saying, right, what are all the good things about this, what are all the limitations, and where can we move on from here? So really that's what we're doing. We're looking at the inherent problems within the evidence-based practice framework that we've learnt about really well over the last 25, 30 years, and before that, of course, and sort of wondering, right, where do we go now? Where do we go now with our scientific methods? Where do we go now with our scientific process and activity? And it's looking at the next stage. And you know, the Cause Health project runs just by chance in parallel with other projects like the Campaign for Real Evidence-Based Medicine, who were asking the same questions. Okay, so 1992 this thing happened. We're some years down the line and we're thinking, well, did it really do what it said on the tin? And a lot of people probably would say no, and so it's saying, but it's done lots of good things, so let's learn from the good things, let's learn from the bad things, and let's learn how we move on. And one sort of central point to thinking about how we move on is looking back over the last 30 years and thinking, this model seems to be good, intuitively good, but did the sort of patient, did the person get lost in all this somewhere over the last 25 years, and now we're wondering, okay, how can we reposition not the patient but the person, the human, with all of this. So patient values is something different to human values. So where does human fit into this? So as I say, what today is not about is being negative. What it is about is being positive and wondering, okay, at this place in scientific history, where are we moving on to? And this is a picture of Austin Bradford Hill. He conducted the first formal randomized control trial in 1952 in medicine, and we've learnt a lot from him, and obviously the world of research has developed sort of from that point leading up to the 1990s, and now, for example, the randomized control trial is a key point of health research. But just to give a sense of progress and a sense of history and a sense of future, the first randomized control trial was really documented in the book of Daniel, in the First Testament. So we could say something like, well, it took about 2,000 years from when it first being thought about to first being implemented in practice. So science works slowly, but during that 2,000 years, there's a lot of work and a lot of thought done. Now, I'd hate to think it's going to be 2,000 years worth of funding from the European Research Councils to keep this going. I think we might move a bit quicker than that, but scientific development and scientific change takes time. So all I'm going to do now, before I introduce the speakers for the day, is throw in my penny's worth and really literally throw in a pebble into the water and let some ripples emerge and see what you think. And I'm going to present what I think is one small but core part of the big cause health thinking and the big cause health project, and that's really about problematizing the methods that we use in evidence-based medicine and wondering what they tell us about this thing called causation. So in other words, I want to look at the evidence-based practice framework and say, what can we learn from that in trying to understand when we say something works, when we say something clinically effective, what do we mean by that? And if we can get to that point and think, right, this is what we mean by that, then we can say, okay, is that meaning of this thing called causation suitable and relevant for what I do every day with my patient? So when I'm with a patient and we're thinking, right, we want to work together to change your health status for the better, is that the same thing as saying this collection of studies over here demonstrated something that you're after, but how similar is it? So first we need to establish what medicine and physiotherapy and evidence-based healthcare means by causation. So this quote here could be considered a central claim of evidence-based medicine, which goes something like, evidence from studies higher up the hierarchy more reliably informs therapeutic decisions. So already we've got a view of what we value in terms of sources of knowledge. Nothing over the next 10 minutes is going to be new to you. I'm just going to reframe it slightly. You know all this. I'm just going to, but just bear with me. So already there's two things there. There's a hierarchy, and we can debate that for a long time, but let's just say there is, because there is. If you look at a non-hierarchical structure like grade that talks about levels of evidence, that's a hierarchy. So we can't get away from research being organised as hierarchical, and we value things at the top different to the stuff at the bottom, and vice versa for different reasons. But in terms of clinical effectiveness, evidence of clinical effectiveness, we value the stuff at the top. So looking at a classic traditional sort of model of evidence-based medicine, and we can add to this and take away over the years. But we've developed this sort of cut-off point of what we think as causal versus non-causal claims. And again, there's a lot of literature and a lot of debate and a lot of narrative around this, but this is what it boils down to. Even the most hardcore commenters, commentators within evidence-based medicine and within philosophy still would have to come back. You can't get away from this point within the evidence-based medicine. And it is that some studies that give us information and knowledge that we class as non-causal, and we might say there's a correlation, there's an association of some sort, but I wouldn't say, I don't trust this sort of stuff enough to say this causes something. But then you look at the stuff at the top and think, well, there's something about those methods that allow me to have more confidence in saying, yeah, I think there's some causation at play here. And so that's how it works. So obviously the stuff that gives us more confidence in making causal claims is stuff that starts to look at comparing groups against each other, comparative studies, like randomized controlled trials, and better still, systematic reviews of high quality randomized controlled trials, and that's what the world of healthcare is sort of based on. So, to put that another way, let's say we have a health condition with a certain baseline, so everybody's sort of ill to that level or painful to that level, and we give those people a treatment and they improve, and then we would say, okay, so you've improved. So we could say, well, the intervention helped, or we could say, well, there's lots of other things that could have been in there that helped as well. So we had a control group and that doesn't change, and this is what gives us that confidence in the causal claim. Well, all of the factors than the intervention, let's say if this was randomised properly, all of the factors within the intervention were the same, so the only thing that was different was the intervention, the invariable thing, the thing that didn't change between the groups. So the best explanation is to say that invariable variable made a difference. Fine, you know all this. So, in terms of framing that in philosophical terms, the best philosophical grounding for that sort of scientific activity, and really the only philosophical grounding, is something based on a Scottish philosopher from Scotland called David Hume, who in the 18th century wrote about causation, and a couple of things he said about it. An object followed by another, where all objects similar to the first are allowed, followed by objects similar to the second. So that's just saying if you do one thing and something else happens, and you do that a lot, then you start to get an idea of causation. Yeah. So if you treat one person and they get better, that doesn't mean much, but if you do it again and again and again, and then if you control that variable and do it to lots of different populations, you see the same thing. That's a dimension of causation, regularly occurring events. And then the other statement he said was, in other words, but this is actually a slightly different concept, where if the first object had not been, the second never existed. So if you don't do that intervention, then they don't get better. So that's so mapping back onto our model. There are two theories of causation at play there. One is the first statement, which we could call a regularities view of causation. Something just happens a lot. Two events happen a lot together, and we establish some sense of causation. But then we had a counterfactual condition. We have a condition where the variable isn't there, counter to the other one, and that says something about causation. So there are two Humean types of causation there, but we can push it a little bit further and say, well, actually, if you're talking about the actual stuff that happened, the real causation, where did it happen? And of course it always happened in this group. So the counterfactual setup, all that's done is add to us as humans some sort of psychological support that we believe something that was happening in the intervention group anyway. So it doesn't add anything to any sort of scientific structure or mechanics to the method. It just allows us to have a bit more psychological confidence in what was going on. But the true causal the true causal activity was there all along in the correlation group. So this is important, because now we can say, well, if we really want to understand the nature of causation, as some sort of theory of causation, then the only place we can look is in that group. So within healthcare, randomized controlled trials are set up as methods to create causal claims, but the truth maker of the causation in that is something that's nothing to actually do with the causation itself. The truth maker is the counterfactual group, but the causation itself is happening in the intervention group. Okay? So we can look closer into the intervention group and say, okay, what is it about it that health science and David Hume was saying about causation within that? Well, there's this idea of one thing followed by another. Okay, we've already said that, regularly occurring events. Snooker cue hits a ball, and there's some sort of causation. But it is just that, it's just one discrete event followed by another. Now, Hume said that to satisfy some sort of notion of causation, three things need to exist: contiguity, temporal priority, and constant conjunction. And if you think about it, all these things happen in a randomized controlled trial and in a game of snooker. So contiguity, they need to be close together. The two events need to be close together. The snooker cue has to hit the ball in some sort of spatial proximity, and an intervention has to be close in some way to the patient. Yeah. Temporal priority, the cue has to come before the ball moving, the intervention has to come before the health improvement, yeah? And constant conjunction, it has to happen time and time again, and then you can be satisfied with causation. So that's all we were saying in the intervention group. And what Hume said, he said he could not see anything other than that as a part of causation. There was no causal substance between the tip of the snooker cue and the ball. You just saw one event and then another. You didn't see this connection, this sort of necessity stuff, whatever, in between it. So, the same in a randomized controlled trial. We just see an event happen, a treatment, and then an effect happen, and a health improvement. Okay, and that says a lot, that gives us a lot of information. But it still seems, from people like Stephen and Rani, there still seems to be something about the causal story that's not been attended to sufficiently for the last 250 years or so. And we're wondering now if Hume had got it right, and we're happy that we just say, yeah, there is nothing else. The world is made up of just discrete events that just happen to happen in some sort of order, and there's nothing else to say about the causal situation. Well, that's an unsatisfactory position for the Cause Health Project and philosophers of science of some types. So what can we do about it? Well, people have tried to address the Humean problem for centuries, and failed to find this necessary connection, failed to find something other than two discrete events happening in some sort of time-space setup. And one reason that might be is because there's been some sort of narrow view of the analysis of the Humean world, and perhaps there's something else, another approach to take, and really that's what the Cause Health taken. So we're sort of building on the fact that perhaps the world doesn't operate on Humean terms at all, and perhaps we can approach this from another way by reconceptualizing the very nature of causation, not trying to fill the gap that Hume left, but trying to reconceptualize the whole world about causation from a very fundamental viewpoint, which takes us really to the starting point into the unobservable world, which is why these guys are actually operate on a daily basis in the unobservable world, in the world of metaphysics, and these really abstract notions. And again, the interesting thing about the Cause Health Project is it's taking extremely abstract metaphysical notions to the shop floor of clinical practice. So the favoured causal theory that's being investigated here is one developed substantially by Stephen and Rani, which is referred to as causal dispositionalism. So we've got the Humean theory of causation, and then a dispositional theory or account of causation. And these two are different things, if you like. Okay. So the causal health problem is trying to address the world of evidence-based medicine, evidence-based practice and evidence-based healthcare through a lens of causal dispositionism and see how that plays out. So the first thing to say is this is something that is not, it doesn't dismiss the methods we have, it embraces the methods we have. So it doesn't say randomized controlled trials don't give us information. They do give us information, but back to that picture with the intervention and the control, the regularity and the counterfactual, we can see there that the randomized controlled trial setup, counterfactual setup, just gives us a belief, it gives us a clue to where causation might be. It's symptomatic of causation, but it's not constitutive of causation, to use one of Stephen's phrases that I enjoy the most. There are a couple of others. I do like that. So, the top end methods of the hierarchy, we say they make causal claims. They make claims where there might be causation at play, but they don't give us a complete picture of what's at play. And of course, there's an empirical defence to back up this stuff. If you look at John Leonardus' work on most research findings of faults, etc., the empirical story ties in with the philosophical story as well. So, and the campaign for real evidence-based medicine story and analysis of the last 20 years ties in with this point as well. It was beautiful in 1992 to think things like systematic reviews of randomized controlled trials would lead us a long way in medicine, and of course they have led us some significant ways. But now learning from those 20, 30 years, we see, well, the bigger chinks and gaps in this than we originally thought. Even the hardest proposals of randomized controlled trials. So what does the new theory look like? Well, I'm not going to explain all that. It will drip feed throughout the day in some different guises, and as I say, over the next 3 years we'll be able to explain more about it. But one phrase here from Stephen and Ronnie's book on dispositionism. So we think not of cause and effect as two discrete events, but the actual causation is the process that's occurring between these events, and that's what we're trying to get to. And in the field of healthcare, we think that process is the human being and what the human being offers the story of evidence-based healthcare. So can we develop scientific methods, or can we read from existing scientific methods something more about the human as a source of evidence for therapeutic effectiveness, and start the evidence-based story there, rather than from a human world trying to push down to something that's not even represented in the human world. And I'm going to leave it there. I think the glass figure there is probably a fair enough analogy. So if the glass falls and smashes, we can say the causation was the pushing of the glass, and the effect was the smashing of the glass, and that would be a Humean description of that. But where was the real causal substance? We would say that was in the disposition of the glass to be fragile. It had this fragility as a disposition, and there was a microorganism around it that allowed that disposition to manifest, but the actual causal substance was within the glass itself. Because I could knock a glass and it could fall onto a soft surface and it would not break. That doesn't mean there was no disposition for it to break. No causation ready to happen. It was just a setup around it. It was different. I'm going to stop there and introduce the team. So, just of course, to point out, not only the Norwegian University of Life Sciences, but the University of Nottingham as an institutional partner for the day and the project. And if you look around you, you'll see some lads and girls in football shirts. So these are representatives from Choose Health, who are our media partners for the day. Hello. And they're going to video and audio capture the whole of the day. And you get set up for some Vox Pop stuff?
Yeah, we'll be doing that. We'll be grabbing people when they're trying to get the teas and coffees and putting you under the cameras. So look forward to that.
Great stuff. And if nobody's ever met Jack Chew, is there now waiting to be shot at up in the... and actually, just looking around, I've never seen so many avatars around in one place before. It's like flicking through Twitter, just looking around. So the players today, I'm going to stay in goal. I've done my bit. I'll keep an eye on the defence, and here are our top two defences. Barry and Stokesy, English and Irish international, just transferred to the team.
That's first.
Yeah. So next, Tracy and Emma are going to give a completely... What's going to be interesting about today is the variance in the presentations, because we're trying to get as wild a story as possible about the state of evidence-based physiotherapy at the moment. So Tracy and Emma are going to give some massive global views from where they sit, but all the time I want to be thinking, I want you guys to be thinking, okay, where does the sort of micro-philosophy fit within all this global stuff as well? What can we make of the political picture in terms of a reconceptualisation of the scientific methods we use? Midfield, Mum Jump, Team Mum Jump. So we're going to get a closer insight into some of the detail of the ontology of causal dispositionism and the theory about that from Stephen and Rani, who are going to talk just after break. And then Moffat from Nottingham is going to follow that up with a sociological view of the same concerns, but from a very different, broad sociological view with respect to the power dynamics and the governmentality that are at play within the world of healthcare. And then we're going to get the wingers in to go take us right to the shop floor. Matt Lowe and Neil Maltby. Hopefully we're going to get some insight into how these two physiotherapists, shop floor physiotherapists, critical thinking clinicians, are starting to utilise a reconceptualised philosophy and let it change their world of practice in terms of the way they reason and they listen to patients and they use information from their patients. So hopefully we'll get a really good view there. And then last but not least, not since 1980, when John Robertson squeezed a shot past the Hamburg keeper for Nottingham Forest to take the European Championships, if we had such a strong and robust striker to finish it off. So hopefully Mick's going to give us some information. You can correct me if I'm wrong here, but about the world of the science of humans and pain. We'll be talking about pain or rats or something. And the idea is the sort of stuff the sort of scientific activity that Mick and Neil and Matt will be talking about is the stuff that traditionally sits really at the bottom of the hierarchy of evidence. And if we get a sense that what these guys are talking about say something to us about causation, what makes people better, what's clinically effective, then immediately we started to question the human world of causation. So so thank you very much, and what we'll do now is I'll introduce Tracy a tiny bit more formally. Now I'm not doing long biographies here, so I got all the speakers last night to write down their biography in 140 characters. So I'm just going to introduce Tracy as a physiotherapist, interim CEO of the WCPT, connecting with #GlobalPT, leading WCPT Congress, moving #Physio forwards. Thank you, Tracy.